And then on this next question, from the ACO's perspective, the Medicare CQMs are seen as a way to optimize your score, right? I have more manual chart abstraction, especially for measure 134. I have a huge population. I can't get to the 24,000, but I can get to the 12,000. And I can improve my performance with manual chart review. And that's really the main attraction, is that manual chart review volumes being much more manageable for the ACOs.
You're right, Laura. That's an interesting observation. I think it may be somewhat of a toss-up what to expect, because there's counteracting events going on here. If it would be entirely true that if your score was based on the absolute value of the performance score, you'd do better. Anything that involves a manual data abstraction tends to score better than the electronic, simply because if you miss data, it's going to reduce your score, not increase it. The nature of reporting is it takes an action, it takes a number to flesh out the high performance. If it's missing, it looks like you didn't do it, even if that number would be good if you found it. So for that matter, you might get you're expected to get a much better raw score from anything that involves manual abstraction, or even just from MIPS CQMs, which we can cast a much broader net to get your answers from the clinical data, whereas eCQMs are got a much narrower approach. You have to have a very specific documentation workflow to make it show up. So your raw numbers are going to be higher, but then you have to realize that they get scored not on the raw numbers as on a curve, or as a percentile rank. So if all of your competitors are highly functioning, you're more likely going to be stacking lower in that list, in that high functioning group, than if eCQMs and MIPS CQMs, your competitors are all practices in the U.S. And I'm expecting that ACOs who are baking this shared savings, they're baking this financial gain into the process, and they're submitting their quality data in order to qualify to collect all of their shared savings. They have a bit more skin in the game. They've got a bit more impetus to perform highly. So the field is more competitive. I expect, therefore, the percentile rankings to put you at a lower level for any particular raw performance than it would from eCQMs to MIPS CQMs. Now, that's not going to be an issue in the first 2 years. Medicare is proposing in the new proposed rule for 2025 that they use raw scores and pre-publish it to tell you what your score is going to be at any performance rate in the first 2 years. It takes 2 years for any new measure or new measure type to generate the historical data from which they typically generate their annual benchmarks.